This is how you usually start a lecture. You thank the organizer. You are happy to be here. And this time I'm particularly happy because finally I start to go back to these events. I think we were all missing this type of interactions. And I think this is why we come to meetings, right? We come to listen to other colleagues, to learn, and also to enjoy life a little bit. And I think this is what we're here for, to enjoy life a little bit, right? So the topic of my presentation is going to be about implantation, mainly, and implantation failure. And we, as Professor Mocano asked before, most of you are clinicians, some of you are scientists. And we know implantation is always called a black box. And why? Because there are many, many things that we don't understand. There's been a lot of research done in this particular process. There are always these beautiful, complicated graphs where you see all these molecules going up and down. And there's still so many things that we don't understand. So we try to understand this language between the embryo and the endometrium, and still it's not an easy process. One of the main reasons why implantation fails, and you all know this, is embryo aneuploidy. And this is why humans do not reproduce very well. If you look at the aneuploidy rate in other species, in Drosophila, in the mice, you see it's very, very low, and it's tremendously high in humans, especially at advanced maternal age. And this is one of the reasons why the chances of being pregnant per month in a fertile couple is very low. Fecundability is around 20–25%, more or less. And if we look at the implantation rate, it's the opposite. You look at other species, they do very well, 95, 96 in the rodents models, in rabbits, and it's very, very low in humans, even with our help of selecting euploid embryos. So there's many things still to improve, and this is one of the reasons why we read and why we study and why we do research and why we go to meetings. We know there's a huge room for improvement. This is a very nice article by a group of experts published not long ago in 2020. I think that was the year that so many papers were written because people were at home and didn't have anything to do. So they start writing papers, and you'll see a rise in publications. But this was a very interesting observation. They looked at the number of couples. If you take the example of 100 couples, how many would really be impossible to get pregnant? And there are not so many. The true couples where fertilization was not possible were obviously sterile couples or couples who didn't have intercourse in the fertile window, where there was no sperm. Then you have the implanting pregnancies, which is about 1/3, as you can see in the bottom, but there's a range of pre-implantation losses. Probably the embryos get created, but they do not implant, and they fail very, very quickly. And there are many, many areas here that we should investigate further to improve the outcome of what we do in the clinics. When we think about selecting embryos by euploidy, then we're happy because we know that if you remove all the abnormal embryos, then implantation should happen. And we know it doesn't. And it's not only that it doesn't happen always, it's that there's also a decrease with age. We tend to think that age is the most relevant factor, and we know that's true, but the chances of a young euploid embryo to implant versus an old euploid embryo is not exactly the same. And this was shown a few years ago, almost 10 years ago, in this small sample size paper, about 500 embryos biopsied on day 3 and about other 500 embryos biopsied on day 5. And you see how there's a decrease in the implantation rate transferring euploid embryos. So there is an impact of age here. We tried to enlarge this, and we analyzed more than 8,000 euploid embryo transfers done in the group of Richard Scott in New Jersey, in EMEA. And Andres Retz published this paper in JARG. And what we saw, this is the age distribution. You have young patients and not so young patients included. And you see that it's not everything about euploidy. You see in this study, we look at the biochemical pregnancy rate, the clinical pregnancy rate, and the live birth rate, which is the final message that we want to deliver to our patients. And we could see how, according to the different age strata, you see there is a decline in the implantation. All of them are single euploid blastocysts of good morphology, and you can see that there's a small decrease when the patient gets old. If you look at the outcome per group, again, you can see out of the 100% embryos transfer, the implantation rate, the clinical pregnancy rate, and the live birth rate decrease with age. So it's not only about the chromosomes. And if you look at the pregnancy loss, it's just the opposite. You will see how there's a higher pregnancy loss in advanced maternal age versus younger patients. And the main loss goes between implantation and clinical pregnancy rate. From clinical to live birth, it's almost stable. There's no impact of age. But the main problem comes from the positive beta-HCG to the clinical pregnancy rate. If you adjust the odds ratio for other confounding variables, you can adjust for AMH, obviously, for the day of embryo transfer, whether it's day 5 or day 6. Even for embryo morphology, you will still see these differences, which is, I think, interesting to understand. And it's not only us saying this, there are many other publications out there. You have this paper in RBM Online published last year in 2021, also from the US. This is Paulson's group in California, and they show also that you can see, it's a bit confusing with so many numbers, but you can see in the top line how these are day 5 good quality blastocysts that were euploid. If you have poor quality, you can see in light blue, there is a significant impact on the blastocyst morphology, even for a euploid embryo. If it's for qualities in between, and obviously if it's day 6, you will have even poorer outcome. So it's not only about being euploid. There will be some discrimination between these different groups. And maybe there's something else beyond age on the oocyte factor. Maybe it's the uterus who is getting old. Maybe there are other areas that we have to look, because I think when we jumped into NGS, PGTA, we thought, well, everything is solved because now we have euploid embryos and the patient is going to get pregnant anyway. So another way to look at the true implantation failure was doing the exercise around. So what we did is how many of the patients that have an embryo transfer, euploid blastocyst transfer, do get pregnant, and of those who don't, what is the chances of having a baby in a second or in a third transfer? So this is what we did. We analyzed almost a little bit more than 4,000 cases, and we saw that about 70% got pregnant in the first attempt. Of those who did not implant, some of them dropped out, as expected. Some of them had remaining embryos that were transferred subsequently, and some others underwent a second ART treatment. Second transfer, again, implantation rate was similar, around 60%. Again, some of them did not get pregnant. A few of them dropped out. Some of them had frozen embryos, and others underwent for the third round of ART. Similar implantation rate, again, in the third round. So if you look at the live birth rate after 3 attempts, you see that it's more or less equivalent in all these 3 first embryo transfers. And if you look at the implantation rate and the likelihood of a heartbeat, it's about 95% after 3 euploids, blastocysts being transferred. And the chances of having a baby at home, it's about 93%. You see that? So this tells us that the true implantation failure is really, really very small. It's mainly an embryo-driven issue. If you have an euploid embryo, more than 90% will have a baby if you are able to have 3 euploid blastocysts. And this is the main difficulty. Many, many times we struggle with these couples to find euploid embryos. So what do we do if you have implantation failure? Let's say we have one of these difficult couples that we all see on a daily basis, I'll say, that they go through PGTA, you transfer euploid embryos, they don't get pregnant, and then you have to give them an explanation. Where should we do investigations? Because if they go into Google, they will come to you with a list of things that we should have tested and we did not. So we have to have some clear arguments to explain to them why we do what we do. We have to focus maybe on an ultrasound evaluation, maybe hysteroscopy, as a few years ago was a hot topic. A few words about scratching, maybe transcriptomics of the endometrial signature, maybe microbiome or immunology. If we talk about ultrasound, I think today we all have fantastic scanners in our offices. And these scanners show us things that we couldn't see in the past. And one of them is adenomyosis. I think today we speak and we talk much more about this disease because we see the disease that we didn't see in the past. We had to refer the patient that we suspected to have an adenomyosis for an MRI, and MRI was the gold standard, and without an MRI, it was not easy to identify adenomyosis unless it was a huge adenomyotic nodule or a big, big lesion. I think today, with the scanners that you will use to measure your follicles, if you pay a little bit of attention, you can identify these 7 features that Naftali described a few years ago. And they're the classical asymmetrical myometrical thickness. You see these asymmetric walls, the parallel shadows that you can see, and the striations. You can see the classical cyst and the hyperechoic island. Sometimes this myometrial mass that they bind together like adenomyomas, and even the endometrial myometrial junction. So you can see this easily. And these features, as I said, you can easily see them in a conventional 2D scan. You don't need to have fancy 3D scanners, uterine reconstruction, or Doppler analysis. It's just paying attention to this globular aspect of the uterus. You see the asymmetry here, very easy. You can see this heterogeneous myometrial texture on the posterior wall here. You see the typical striations that you can find in 2D, or of course the cyst or the hyperechoic nodules that are classically described. So the interesting thing is that there's a very nice correlation between these features and the clinical outcome. So if you have no adenomyotic lesions in your uterus, this is your clinical pregnancy rate. And you have 1 or 2 or 3 or 7 of these features, there's a clear correlation with the decreased outcome. So obviously, this is one of the things that may be compromising the success rates, even if you have euploid blastocyst to transfer. If you look at the gene expression of this endometrium of women with adenomyosis, like most of the times you study genes, you will have genes that go up and down. You will find 500 genes going up and 500 going down. But then you have to interpret this and have someone to explain to us, clinicians, what does this mean. Even if you don't know anything about molecular biology, you see that here, you see in this heat panel, a lot of greens, and here a lot of reds. So that means that obviously this population is different, and if you look carefully into this data, you will find 34 genes that are dysregulated in these patients. So this could be one of the reasons why you have lower implantation rate and higher miscarriage rate in these patients. If we talk about hysteroscopy, I think the question has been answered, but a few years ago, and not that long ago, this paper was published in 2016, there was like a hype on doing hysteroscopy, routine hysteroscopy to all of the patients undergoing IVF, because maybe you could find in the hysteroscopy some lesions that you may miss in the ultrasound scan. But as I said before, I think the scanners that we have today are so good that you can identify almost anything that then you will confirm in the hysteroscopy. But it's very, very rare that you find in the hysteroscopy things that you did not see in the scan. Maybe you will find filmy adhesions, but some of these are difficult to justify the implantation failure. So this was the trophy trial. I'm sure you have read this paper before. Multi-center randomized trial with 8 hospitals involved in different countries, 700 women randomized, and whether they had a hysteroscopy before the IVF cycle or no hysteroscopy, as you can see in the outcome, it was exactly the same. So it doesn't seem to help to do a routine hysteroscopy to all of your IVF patients. If you talk about the scratching, it's a little bit more the same. This is a recent paper. It published in a great journal, New England Journal of Medicine, 2019. Again, randomized controlled study in which patients were randomized, 690 patients, with a huge randomized trial. You know how difficult it is to run these trials. 690 were randomized to endometrial scratch, the other half no scratching, and again, exactly the same outcome when you look at the clinical pregnancy rate and all the different variables. So it doesn't seem to be a role for endometrial scratching as a routine. If you talk about endometrial transcriptomics, I think we are still at the early times of this data, but I think it's really fascinating because finally we're starting to see the endometrium in a different way. We used to look at endometrium just with a scan, and if it was a nice thickness and maybe the texture, maybe triple line, we were happy or not so happy. But now we can understand something else, and it seems that there's a time where some of these genes should be expressed, and this could be advanced or delayed. But of course, this is not the ultimate truth. There's still a lot of controversy in the data coming from this test. The ERA test was one of the first ones. There are many others in the market. And as I explained here, there are different commercially available tests, but there's no single independent study that shows a beneficial effect. Most of them are done by the people who sell the test, and this obviously carries along a little bit of bias. And in fact, this is an abstract that was presented in ASRM last October. I think it's a very interesting study, and it shows in a randomized controlled trial, if you transfer your euploid blastocyst, so these are women undergoing PGTA through NGS, you have an euploid blastocyst, and then you transfer according to the ERA results or according to a standard practice. And as you can see, this is still not a paper, still an abstract, but you can see that the results are exactly the same. So it seems that in general population, the transcriptomics still today do not seem to help very much. But I'm thinking, and this is the way I understand this data, this is the generation 1.0. I'm waiting for the generation 2.0 to come because I think transcriptomics still have many things to say in our practice. And if you look at the different papers published out there, you will find papers that look at the displacement of the window of implantation. You will find papers showing about the pathology, so maybe not the displacement, but if there's a functional or dysfunctional endometrium. Papers that look at both of them. And if you look at the genes that they investigate, it's interesting that they don't agree with the genes that should be expressed. So still, I think, further research is needed here for sure. Same with microbiome analysis. Microbiome is today a hot topic, and it affects everything. And the dysbiosis is related to cancer and to diabetes and to heart disease and, of course, to fertility. And patients know about it, and they buy probiotics in the supermarket, and they take it. And is this correct? Is this not correct? Well, I think we still need to know what do we need to know, because we don't know yet what is normal and what is pathologic. But it still is the same. There are no independent, well-done studies published, and the way you investigate the microbiota is very, very different, where you use NGS, that you will have hundreds of topics and different information that sometimes we don't really know how to handle, or whether you focus on 2 or 3 topics only using QRT-PCR. So again, many things to be understood prior to jumping into treating or over-treating our patients. We published this review in RBM the year of the publications, 2020, and it's a group of experts that we try to summary the information regarding dysbiosis and microbiome. Because we have to remember that IVF is not an sterile procedure. If you look at the sperm, you will find bacteria in the sperm. If you look at the washed sperm, you will find bacteria there. If you look, of course, at the incubated sperm, you will find bacteria. And if you look at the IVF culture solution or media, you will find bacteria. So we have to know which bacteria should be there and which bacteria we should get rid of. And they're starting to see some publications showing some of the benefits of giving oral probiotics to patients. It's still early stages, but if you look at this paper in RBM Online published last year, you see that you may reduce the diversity index by giving oral probiotics. And we know this is a good thing, but still there is no clear correlation, and if you look at the p-value, it's still non-significant. And you have papers that say just exactly the opposite. You see this paper from Japan, where they did a transfer. At the time of the transfer, they took the tip of the catheter in 100 patients undergoing a frozen embryo replacement, and they look at the endometrial microbiota at the time of the transfer, but they did the transfer anyway. And then they look at the outcome. And if they found a dysbiotic endometria in 1 in 3, more or less, 31%. But when you look at the pregnancy rate and the miscarriage rate, it seemed to be the same, whether the endometrium was eubiotic or dysbiotic. So again, maybe this is not for everyone. Maybe this should be for focused patients. There's a study actually being run in Denmark, and I think this is one of the good ways to have a clear answer to our questions, and this is people who are brave enough to randomize patients and to do this type of trials. This is the group of Thomas Haar and Peter Humaydan, and what they are doing is randomizing patients into 3 arms, 333 patients, and they treat patients that have been tested positive for 2 bacteria, with antibiotic and probiotic, second arm antibiotic and placebo, and third arm only placebo. And when the study is finished, we will understand if this is through an advancement or if this is just over-treating patients with no focus. And more or less the same with immunology. There's a lot of noise and a lot of questions from our patients saying, should I test for my NK cells? Should I take an endometrial biopsy? What about corticoids? And we all have this concept in mind that if you do ovarian stimulation, you may have an altered endometrial immune environment. So maybe it could be better to use a frozen embryo replacement. And we haven't been able to see that. We have tested some of these volunteers and patients, and they were offered to take a biopsy of the endometrium in a natural cycle, in a stimulated cycle, and we did immunohistochemistry of these patients. We looked, not follicle count, that's a mistake, it's actually flow cytometry to check for the number and percentage of immune cells, to check for uterine NK binding to a kind of an artificial embryo, what would be the HLA-C tetramer, and also gene expression of TNF-alpha and IL-10. And we described in this paper published by Diana Alexandrou in 2020 that ovarian stimulation did not affect the uterine immune cell population or the binding capacity of these uterine NK cells to this artificial embryo. So I think we can conclude, sorry to be so fast, it's quite sensitive. We can conclude that the main driver of implantation is, without any question, the embryo. We need to focus more on embryo selection and try to explain the couple if this embryo that we transfer is truly going to make a baby or not, and we're still far from there. True implantation failure is very uncommon, as Paul Pirtea showed in his paper. It's about 5 to 10% of the failed cycles only. And there's a lot of new papers coming out on how to define implantation failure today. I think we need to consider a little bit better, pay more attention to the uterine morphology, pay more attention to the data that is coming about endometrial signature through transcriptomic, and of course keep our eyes open about the microbiome and the immunology, because still many things need to be understood. Thank you very much.
Thank you very much, Professor Garcia Velasco. Really an interesting and updated presentation. Before we go to the questions, I have, as usual, a critical question. You know that many societies today are very hostile against genetic assessment of an embryo. You know that in the UK they push the red button on the genetic testing. But you clearly demonstrate here that 95% of true implantation failures are due to chromosomal abnormalities of an embryo. Everything else is 5%. That's what you have demonstrated. Is it no genetic expression of the endometrium? Is it immunological? Is it microbiota? This is all 5%. So common things are common. 95% is because we are dealing with an embryo which is chromosomally abnormal. Yet, we should not test those embryos. Could you comment on that?
Well, I think the way we practice and the way we treat our patients should be driven by data. And we may have opinions, of course, but I think we have to trust data. And data is not always black or white. I agree. There's always things that change and require some time to convince everyone that this is the true evidence. But I think the way the embryo biopsy is done today and the way the biopsy is analyzed, if you look at the non-selection trials where you transfer embryos that have been tested without knowing the answer, and then you see that all those embryos that didn't implant or were a miscarriage could be identified in advance. And those that you transfer, of course, could be successful or not, but you will not have a problem with them. I think this is extremely convincing. Now, it doesn't come from one group. It comes from many different groups across the world. So then it will depend again on many of the things that are related to ethics and regulations and cost effectiveness, and it depends on who pays what. But I think the data is convincing, at least to explain to your patient what you can do with technology, and then it's up to the patient and to you to come to an agreement and see what is reasonable. But to me, it's out of the question today that testing the embryo significantly shortens time to pregnancy, reduces or minimizes as much as possible the miscarriage rate and the complications. But of course, it's not going to make a wrong embryo still a good embryo.
I'm happy that you mentioned this so-called non-selection study, which Richard Scott's group beautifully published, I think 1.5 to 2 years ago, where clearly they demonstrated they didn't have any healthy live birth with an abnormal embryo. On the other side, we had a debate with Kogi a few months ago in Berlin. You know that there is a recent paper published in New England completely against genetic testing of the embryos, with a commentary of Sebastian Massenbrook that this should be only done in studies. Now, I think it is important when you crash a car, it's not always the car, sometimes it's also the driver. Maybe that's the point that we should keep in mind, because societies are going to use this data to prevent us doing clinically genetic testing of the embryos.
Yeah, but you know that the New England Journal of Medicine is more, it's like one of the Bibles. I've never published it. I wish someday, maybe. But when you have a paper from the New England, you always trust that it has gone through a nice review process, and the data is solid and is well constructed and well elaborated. But of course, it's not perfect. So I think, again, as I mentioned before, you have to read data from different papers, different groups, and this particular paper from the New England Journal of Medicine, I'm sure in many of your hospitals and units has been a part of the journal club. I'm sure it's been part of the discussion, because it's far from perfect. I think it has a lot of misinterpretations, and I think it doesn't represent the reality from my point of view.
Great. So many questions, so please short answers. Is it worth to test KIR receptors in recurrent implantation failure?
Well, I think KIR receptors are interesting as an explanation of some of these failures, but I think it's still not something that should be done clinically. I think it should be under a research environment, under clinical trials. I think because information is now on the web, patients read about it, and they want you to test KIR receptors, and if they're not a favorable combination with the HLA of the couple, then they want to be treated, and I'm sure that we are over-treating couples still today, and we have not identified there's no randomized trial showing if by treating these couples with KIR HLA misalignment, you improve the outcome. You know that the misalignment gives you a worse outcome, but there's no clear treatment for that. So I would go for research.
Just for simple clinician, could you give us an example of a bad combination?
Well, the worst combination, if you speak simply, you have KIR AA, AB, and BB, and you have HLA, C1, and C2, right? So KIR AA and HLA C2, C2 would be probably the worst combination. These are the ones that have less implantation and more miscarriages in egg donation.
Okay. What is the role of chronic endometritis in recurrent implantation failure?
It's good that you asked that question, because this has been a topic also of interest for years. And if I recall correct, you published a paper where it showed that testing positive for EC didn't really matter. But I think, again, the way chronic endometritis is being diagnosed today through culture and through hysteroscopy by image or through molecular biology is completely different. And then you can check for these CD138 cells, and the agreement with molecular biology is quite weak, and the agreement with the hysteroscopy looking at images is quite weak. So again, we cannot easily diagnose chronic endometritis, but if you suspect that you have chronic endometritis, the treatment is simple and is harmless, which is antibiotic for a week.
Maybe I can give you a short comment on that. We published a case in Fertility, Sterility 15 years ago. There was an ophthalmologist in our university in Brussels. She came to me, and we did a hysteroscopy. Clearly chronic endometritis, confirmed on every aspect, hysteroscopic biopsy. And she asked me, what should we do? I said, I don't know, because there is no clear evidence what to do. She said, I don't want to take any medication, let's go ahead. We went ahead, and she delivered a healthy baby without any treatment. So I think there is still a lack of knowledge on that. Now, a more challenging topic is, as you mentioned, adenomyosis. Any solution for that?
Not a yes or no. There's some evidence, and there's some couple papers published last year on the benefit of giving generate agonists for 1 to 3 months. There's a paper from China and a paper from the UK showing that. But still, if you think about adenomyosis, what it's doing to the uterus is just creating an inflammatory environment. And we know too much inflammation is not good. We need inflammation, but not too much. So probably what you do with the agonist or even with the pill continuously is to minimize this inflammation environment. If you have a clear patient with adenomyosis that cannot be operated, my suggestion is use antagonists, because this is the only thing that we have today that could work. Maybe the other antagonist in the future could be an ad, but still the evidence is minimal.
When should we start looking into the laboratory failure if we have repetitive implantation failure?
Well, I think we identify the lab failure before implantation failure. If you have poor quality gametes, if you have poor fertilization, if you have poor embryo development, that's even before the embryo biopsy. Or if you have poor outcome after your tubing and biopsy. But I think it's mainly a quality control that you do on a daily basis or on a weekly basis or a monthly basis according to your lab.
Any role for PRP?
PRP. That's a great question. I read the other day on Twitter, someone said, could you please stop injecting PRP into everything? Well, PRP still is promising. I think the data out there is still challenging, and I think it's attractive because you see that some women, for instance, with thin endometrium, when you give PRP to them, they don't get a thicker endometrium, but they seem to get better implantation rates. So probably these growth factors within the PRP may help the implantation process. But still, I think it's preliminary and it's experimental. And I'm optimistic, but still skeptical.
Okay. The last question, do you have any opinion regarding oxytocin receptor modulators like Nola-Z-Bound study in recurrent implantation failure?
Well, that was one of the things. In research, this happens many times. You have a hypothesis, you have a model that works in vitro, and then you try to translate this into the clinical practice, and not everything works. In fact, most of the things do not work. And the oxytocin antagonist, the oxytocin receptor antagonist, was one of these stories. It was a very promising idea. The early studies were really promising, but then the randomized control trial with a placebo didn't work. And this was presented in ESRE 1 or 2 years ago. So I think it's probably the end of the story.
Okay. Any questions from the audience live? Yes, please.
Do you have a microphone there? No. Yes, here.
Thank you. Do you think that a quality, do you think that the laboratory quality should be measured by the pregnancy rates after all transfers of 3 euploid blastocysts?
Well, I think there are many parameters in a lab that can give you an estimate of how well they're doing. And I think this is part of your quality control and quality assurance that you do, at least we do monthly. And you can identify issues that probably, the first alarm is the drop in the implantation rate. But I think these things usually come to you before that, because you may have a lower fertilization rate or lower blastulation rate. And you have a low blastulation rate, then this is the first alarm. Something is happening in the culture. And I think the most stable embryo culture is the best parameter for a successful implantation. Because then, of course, implantation depends on who is doing what. I mean, how careful are you at the embryo transfer, how the procedure went, if it was transfer number 1 or transfer number 20 and you were too busy and running to see more patients. So all the things are important, but I think the lab is what makes the big difference. And when you look at the data from different groups, the most important part of any unit is the lab. And we as doctors are the ones who are in front of the patient, and they think we are the heroes here, but we are not. We are about 30% of the success. 70% is the lab. And if you have a good lab, this is going to make a big difference.
Maybe I can comment on that. We just published last week a paper with several thousand embryos, because indeed we wanted to see if you do a genetic assessment of an embryo and you put them all with a certain hours of progesterone exposure, it means you respect the window of implantation. What are the variables predicting that the patient is going to have a baby? Because you have excluded the genetic factor, mostly with these patients. And the best thing which came out is the quality of ICM, not a trophectoderm. So basically, according to Gardner, you have the description of ICM and trophectoderm. Independent if you have a day 5 or day 6 blastocyst, the quality of the ICM, if it is C or less than C, is the biggest predictor. Not age, not BMI, nothing else except the quality. So I think this is also an important issue to look when we look on genetic screening and chance and age. Maybe with age or lower AMH, you're having lower quality ICM. And for me, it was very interesting because it's not trophectoderm. You might have trophectoderm quality C, but if your ICM is A or B, you still have beautiful chances of implantation. Having said that, thank you very much, Professor Garcia Velasco.